Hi everyone, my name is Mina Ostovari and I'm a lead research investigator at Christiana Care Health System. In this presentation, I will talk about a project we started working on early in the COVID-19 pandemic. In this project, we present an approach to facilitate the control of nosocomial outbreaks of COVID-19. I have no conflicts of interest to disclose. Nosocomial infections are infections that originate or take place in a hospital. In hospitals, if an outbreak happens, the hospital infection control program is responsible for taking actions and minimize the spread of the disease. One of the actions they take in such situation is contact tracing. Contact tracing is the process of identifying those who may have come into close contacts with an infected person and working with them to take the appropriate actions and interrupt the transmission of the disease. Contact tracing has been a controversial issue over the past year during the COVID-19 pandemic. In some countries, personal phone data were used to track the location of individuals for this purpose. In other countries, such approaches were not acceptable and other solutions were suggested. For example, Apple and Google worked together and made an exposure notification system. Public health authorities use this system to design customized contact tracing apps. This system is also supposed to protect the privacy of people using it. While this is a great effort, it requires that public health authorities develop the app, people have access to smartphones, download the app, and use it properly. Therefore, we could see that there are challenges with contact tracing, including ethical issues, privacy violation concerns, policies, and governance. Many hospitals continue to perform traditional contact tracing efforts to control the outbreak of COVID-19 among patients or providers, although these efforts could become cumbersome due to the high transmission rate of the disease. Early in the pandemic last year, one of my colleagues, a physician scientist, asked me if I could use social network analysis to model the interaction of healthcare providers and flag what type of healthcare providers had high-risk interactions with COVID-19 patients. I have talked about social network analysis or SNA in previous presentation. SNA is a technique to model relations between people, either individuals or groups. Note present those individuals or groups that we are interested in, and they could be connected through edges. The edges represent relations that we define based on our question. For example, if we are interested in developing a friendship network, we can define nodes as individuals, and if they are friends or have friends in common, then we can connect them through an edge. When we apply the social network analysis approach to epidemiology, the network that we develop is called a contact network. Using measures of social network analysis, for example, centrality measures, we can identify nodes that could play a significant role in the transmission of the disease. The main challenge that we had in this project was access to data about healthcare providers' location or exposure records to COVID-19. We were not able to get access to such data, and therefore we had to use electronic health records to develop the network. In electronic health records, you could see patient information, for example, what units they were in or whether they were diagnosed with COVID-19. We were interested in developing a network of healthcare providers and therefore had to use the data in the EHR to define some sort of relations between healthcare workers. To flag healthcare providers with high-risk interactions with patients, we defined the study patient population as those patients who did not go to the hospital for COVID-19, but were tested positive sometime after their admission. Therefore, from the time they were admitted to the hospital to the time they were tested positive and went into COVID isolation, the healthcare providers who provided care to these patients could be at higher risk of getting exposed to the virus, as the patients could have been asymptomatic during that time. To generate the network, we use social network analysis. To accurately identify healthcare providers with high-risk contacts with COVID-19 patients, we categorize them to different groups, for example, clinical, administrative, and so on. For each group, we extracted the associated clinical event codes from the EHR. The physician scientist in our team and also another resident went over the clinical event codes for each group and ranked them to no contact with patients, potential contacts, and definite contacts. We removed administrative staff from the analysis as they did not have contacts with patients and their work could be done remotely. To accurately identify healthcare providers with high-risk contacts with COVID-19 patients, we categorize them to different groups. For example, clinical, administrative, and so on. For each group, we extracted their associated clinical event codes from the EHR. The physician scientist in our team and also a resident went over the clinical events separately for each group and ranked them to no contacts with patient, potential contacts, and definite contacts. Based on this procedure, we removed administrative staff from the analysis as they did not have contacts with patients and their work could be done remotely. In our network, healthcare providers were presented by the nodes and they were connected if they provided care to the same group of patients. These patients could be patients with COVID or without COVID. The edge weight represented the number of shared patients between healthcare providers. We also flagged those healthcare providers who provided care to patients with COVID before the patient went into COVID isolation. The network was undirected, meaning there was no direction on the edges. It was also weighted, meaning the edges had weights, and the network was connected, meaning all the nodes were connected directly or indirectly. This shows the high density of the network. There were 21,000 patients, including 863 patients with COVID, represented by the edges of the network. There were close to 4,000 nodes in the network that represent healthcare providers and 367,000 edges in the network. The average edge weight, meaning patients shared between healthcare providers, was 2. We use centrality measures of social network analysis to identify nodes that could play a significant role in the transmission of the disease. Degree centrality identifies the number of connections of each node. Betweenness centrality identifies nodes that could be considered as a bridge. For example, you may consider a node with 2 edges, and through one edge is connected to one big group of nodes, and through the other edge it could be connected to the whole network or another big group of nodes. If this node gets infected from one group, then it can transmit the disease to this other group. So this node can be considered as having high betweenness centrality. Closeness centrality is also another important measure in contact network. If a node has high closeness centrality, it means that it has better access to other nodes in the network and therefore it could transmit the disease easier. As you can see, based on degree centrality, respiratory staffs were identified as being central in the network. And these providers also had high-risk contact with patients, meaning they provided care to a COVID-19 patients before the patients went into COVID isolation sometime after their admission. Based on the betweenness centrality, we have a doctor identified as being central in the whole network, and this doctor did not provide care to a COVID-19 patients before a patient went into COVID isolation. And based on closeness centrality, we have a dialysis staff also flagged as having high-risk exposure, meaning providing care to a patient with COVID-19 before the patients went into COVID isolation. We also use the Louvain community detection algorithm on the network to identify groups of nodes more densely connected. There are different types of community detection algorithms, and depending on the size of the network and the goal, you could choose what algorithm serves your purpose. The algorithm identified 8 communities in the network. These communities could be considered as subdivisions of the network with denser connections between the nodes. The communities had between 132 to 1,421 nodes. We applied the centrality measures, degree, betweenness, and closeness on each community to identify the central nodes. The central nodes identified based on these centrality measures were respiratory staff, patient care technician, and registered nurse. Although we could not get access to the exposure data of healthcare providers, using the research approach, we were able to provide perspective to the infection prevention program regarding what type of healthcare providers had higher risk contacts with patients and also had higher number of interactions with other healthcare providers. Such information could help with policymaking regarding the usage of personal protection equipment, PPE, and resource allocation. Also, as infection programs have access to the exposure data, they could compare their data to this finding and see if providers we identified as central in our network were also infected by COVID-19. In that case, they could modify the medical procedures and PPE protocols to minimize the spread of the disease. I would like to thank the project team, especially our data analysts, for his efforts. I would also like to acknowledge Delaware CTR program and the Mentor Research Development Award, MRDA, that provided me the opportunity to develop projects and progress in my career. Thank you so much for accompanying me during this presentation, and I am happy to answer any questions you might have about this project.